Good day, colleagues. My name is Michael Scher. I am one of the faculty members at the University of Florida College of Veterinary Medicine, where I practice small animal medicine and teach the small animal endocrinology course. What we're going to do today is give you an overview of the essentials regarding small animal endocrinology. Certainly I cannot cover everything, but we'll cover enough information that will hopefully give you an idea as to what is important in today's small animal practice. So without any further ado, we will proceed, and I will give you an overview over the next 60 to 75 minutes. Okay, we're going to start off with diabetes mellitus. And as shown on this illustration, we find that the body will produce insulin from the beta cells in the islets of Langerhans, which is shown at the lower left corner. And from the beta cells, those insulin molecules will go into the bloodstream, where they go to the peripheral tissues from there, where they must attach to receptor sites and then go through various post-receptor processing reactions before we get the desired biological response. And it is at this receptor and post-receptor area that clinically we could run into problems when we're discussing the insulin-resistant diabetic dog and cat. On this next slide, we see an illustration taken from the SEBA collection from the Frank Netter series, illustrating the pathophysiology of diabetes mellitus in a simplistic form. And what essentially happens, we have glucose molecules accumulating in the bloodstream, and the peripheral tissues, namely the skeletal muscle and the peripheral fat, out in the upper left and right corners of the diagram. We have a situation with insulin deficiency. We have the blood glucose being unable to be utilized peripherally, and therefore the blood glucose level will increase and eventually exceed a tubular maximum threshold for the kidney. And when that is reached at around 200 to 300 milligram per DL, depending on whether we're talking about a dog or a cat. And when we get this osmotic threshold, the glycosuria will occur, and we'll get the osmotic diuresis, giving you glycosuria, along with the loss of water and the various electrolytes such as sodium, potassium, and phosphorus that can lead to electrolyte deficiencies in the clinical diabetic. We see in the center of this illustration a picture of the animal's liver, and in the diabetic state, the liver has an uncontrollable output of glucose via the mechanism of gluconeogenesis that sustains the hyperglycemia even when the patient is no longer eating. As the diabetes condition proceeds untreated, eventually we will end up with the ketoacidotic state, with the elaboration of acetoacetate and beta-hydroxybutyrate, which are the organic ketone acids. The routine management of the outpatient diabetic entails the owner having to give insulin injections on a daily basis. And the most commonly used insulins will vary from practitioner to practitioner. Here I show you NPH and Rente, which are classified as intermediate-acting insulins. These are given exclusively subcutaneously, and we usually start off at a dose of 1/4 unit per pound subcutaneously, and that 1/4 unit per pound is the daily dose, which is divided every 12 hours, so that we give the insulin on a BID basis. And we'll find that this will be more comfortably received by the patient as opposed to getting one large dose once a day, which could lead to a precipitous decline in blood glucose. We can also use ultralente and protamine zinc insulins in a manner similar to the NPH and Lente on the outpatient management of the diabetic dog and cat. Again, we use these latter forms on a BID basis as well. For monitoring your patients, there are several tests that you can choose from. The blood glucose curve is the most commonly used in veterinary practice today, where the owner will give the insulin at home in the morning and feed the patient, then bring the dog or cat to your facility, where you will proceed to take blood samples on an every 2-hour basis and monitor the blood glucose curve over the next 8 to 10 hours, thus giving you a feel for what that patient is doing in response to that morning's insulin injection. Spot blood glucose determinations are highly inaccurate for getting a feel for what the animal is doing throughout the day. Urine glucose is a semi-quantitative parameter that we can use to get a feel for what the patient is doing at home. Ideally, if we could get those urine samples on a morning and afternoon basis. The hemoglobin A1C and the fructosamine parameters give us a 3 to 4 week trend for how these animals are doing at home. When we look at the hemoglobin A1C and the fructosamine, we're basically dealing with proteins that are covered with glucose, and as the concentration of the sugar-coated protein increases, it reflects a dysregulation state in the diabetic pet at home. So certain normal values are provided in the laboratories where you will have this particular test done. And again, they just give you an average readout for what that animal is doing at home in the insulin-treated diabetic patient. When we're faced with situations of insulin resistance, it usually entails a dog or a cat that is requiring more than 1.7 units per kilogram of insulin per day. And various conditions can cause this, namely estrus or diestrus in the intact female diabetic dog. We're not sure about what the intact female cat will do. This problem has been experienced more so in the diabetic dog and cat, and that's why, in the diabetic dog, thereby requiring us to recommend that the intact female diabetic pet be neutered as soon as the diabetic diagnosis is made. Progestogen treatments can also cause insulin resistance, as can acromegaly, Cushing's syndrome, and bacterial infections. In this latter condition, we're talking about the endogenous stress hormones that are released from this apparent infection in these patients. This next slide illustrates the activity of the oral hypoglycemic agent glipizide, which is the only oral hypoglycemic agent that is used for treating the diabetic pet. In fact, the oral hypoglycemics are restricted for use in cats only. The diabetic dog is exclusively insulin dependent as far as we're concerned as veterinary practitioners. Perhaps 50% of your diabetic cats will respond to the oral hypoglycemic drug glipizide. And what glipizide does, as shown in this illustration, it facilitates the animal's own insulin toward being secreted and utilized peripherally in a more effective manner. When we're discussing the ketoacidotic patients, we're looking at an animal that is clinically decompensating. It's usually stopped eating. It is now vomiting perhaps. It's been drinking and urinating a lot. And these patients can either walk into your office or they can be carried in. And when they're carried in, of course, it's more of an emergent situation. To detect ketones, we use the acid test reagent disc or tablets, It operates on the basis of a nitroprusside chemical reagent, and it is highly sensitive to the presence of acetoacetate. Beta-hydroxybutyrate, the other ketone body, is not detected with this test. So in a situation where you have an exclusive beta-hydroxybutyrate, diabetic ketoacidosis, we might have a patient that's very sick with a metabolic acidosis, yet it's ketone negative because of the preponderance of the beta-hydroxybutyrate. But in this real world, acetoacetate is usually represented, and therefore it allows for its detection in most of our diabetic dogs and cats. Acetone is a side product from the metabolism of acetoacetate. It will also register a positive acid test reagent disc assessment, but note that the acetone is not an organic acid as acetoacetate and beta-hydroxybutyrate are. The ketoacidotic patient might be hyperventilating to help compensate for its metabolic ketoacidosis. Here we see a little cockapoo mix, a female. She was very sick on presentation. She was vomiting after going through a 3-week course of polydipsia polyuria. She's no longer eating. We have a Foley catheter in her urethra and an IV catheter, and we're monitoring the amount of fluids that are going in as well as those that are going out. On this next slide, I just want to illustrate the biochemical abnormalities that we could see in our sick ketoacidotic patients. Aside from the hyperglycemia and the positive ketone test, we might find that these patients might have decompensated renal function, as shown by elevations in the urine and the creatinine levels, their liver enzymes, including the alkaline phosphatase, the ALT, which is represented here by the SGPT, or the AST, as represented by the SGOT, can also be elevated, the degree of which is influenced by the amount of hepatic lipidosis that is formed in this decompensated diabetic patient. Electrolytes are oftentimes abnormal in the sick diabetic. Although the sodium-potassium levels might be normal here in this dog, they might be very abnormal in another patient that comes in, or we might see abnormalities on day 2 and day 3, therefore requiring us to monitor the electrolytes as often as we look at the serum or plasma glucose levels. The principles of treating a diabetic are several, and I'm just going to discuss these as they're listed. We want to correct dehydration with an isotonic balanced salt solution such as lactated ringers or 0.9% saline. We want to replace electrolyte deficiencies, keeping real close eye on the serum potassium level. It's very frequent where we have to supplement with potassium chloride. Sometimes you have to supplement with phosphorus as well in the form of potassium phosphate. Using regular crystalline insulin, you can give that either IV, IM, or sub-Q. If the patient comes in walking and is not in hypovolemic shock, I prefer to use the regular insulin sub-Q. If they're in hypovolemic shock, we have to give regular insulin by either the intravenous or the intramuscular routes. I usually start off this particular drug at a quarter unit per pound when I'm giving it sub-Q, and I will titrate to effect, depending on the animal's response, on an every 4 to 6 hour basis. I reserve the use of bicarbonate supplements in those situations where we have a severe metabolic acidosis, as would be illustrated when the pH measures at a level of less than 7.1. We provide for carbohydrate supplementation when the regular insulin brings that blood glucose down to 250 milligram per DL or less. We want to, at that point, supplement the intravenous fluids with 2.5% or 5% dextrose solution so that if we continue with our insulin injections to help offset the ketoacidosis, we will not iatrogenically make that patient hypoglycemic. Here we see a little Cocker Spaniel. Her name is Twinkle, and it's obvious to you at this point that her right eye shows whiteness, particularly due to the fact that she has a cataract in that right eye. Now, diabetic cataracts are common in the dog, but they are not common in the cat for specific physiologic reasons, dealing with a pathway known as the sorbitol polyol pathway, which is more readily called to work in the canine diabetic, but not so much in the feline. We oftentimes will find bilateral cataracts that will require surgical removal. Here we see a kitty that is diabetic, showing you the classic plantar posture, illustrating diabetic neuropathy, and this will be a reversible problem once you get this patient under better diabetic control. It takes several weeks for them to regain normal use of their rear limbs when they come in this way. Dogs also get diabetic neuropathy. They will not walk in this plantar posture like cats do, but instead they will present more as paraparetic dogs, with the owner's complaint being that they're weak in the rear limbs. Okay, let's leave the diabetic patient and I'll give you an overview of hypoglycemia. Hypoglycemia is a very dangerous condition for the body, obviously because the brain is adversely affected, as shown here in this diabetic cat that went into an insulin reaction while the owners were away and subsequently experienced severe damage to its cerebral cortex and its brainstem. Here we show you an illustration of the human brain, but we'll pretend it's a canine or feline brain. And I just want you to take note that the two areas that are adversely affected by hypoglycemia are the cerebral cortex and the brainstem, both areas of which are involved with maintaining the state of watchful or wakeful consciousness in the animal body. Now, severe hypoglycemia might present with partially reversible or irreversible effects on that animal. It depends on the degree of the metabolic insult on this patient as far as how it will adversely affect the brain. The causes of hypoglycemia in our veterinary patients are several, and I will list these. Insulinoma, extrapancreatic tumors such as large fibrosarcomas or liposarcomas, or rhabdomyosarcomas, the latter of which might produce insulin-like factors that can cause the hypoglycemia in these extrapancreatic tumors. Addison's disease can have hypoglycemic patients in approximately 20% of all Addison's disease. Liver disease can cause hypoglycemia in the end-stage liver when the storehouse of metabolic machinery breaks down, so to speak, and the patient can no longer undergo glycogenolysis and gluconeogenic capabilities. Sepsis can lower the blood glucose to very low amounts, such as 20 to 30 milligram per DL. Why? Because sepsis can set up an anaerobic environment at the cellular level, leading to an inefficient production of ATP, subsequently causing the animal to have a low energy reserve. Starvation can be associated with hypoglycemia in the dog and the cat, but this most commonly affects the pediatric group because they lack the efficient metabolic machinery of energy turnover that is found in the adult dog and cat. Here we show you an illustration of a canine pancreas, and right in the middle of that we see that darkly pigmented nodule representing the insulinoma. The insulinoma in the dog is a bad disease, so to speak, because over 90% of these are adenocarcinomas with a likelihood of metastasis to the liver and to other body areas. Therefore, it behooves us to always give a very guarded prognosis to any patient that has an insulinoma. And the same applies to the ferret and to the cat, where most of these are malignant tumors. The diagnosis of insulinoma is based on your clinical demonstration of the patient having an inappropriate hyperinsulinemia with coexistent hypoglycemia. Normally, you would expect a hypoglycemic animal to shut off its insulin secretory capability, so it would be highly inappropriate to have an increased level of insulin in the blood while the patient's blood glucose is low. The medical treatment of an insulinoma will be brought to use in the patient who is operated successfully but then goes on to have recurrent signs due to the metastatic disease. And to medically handle these, we use frequent feeding and prednisone or prednisolone. The drug diazoxide was more readily available in years past. It would inhibit the insulin secretory capabilities of the tumor, but do nothing for the malignant characteristics of the insulinoma. Diazoxide today is difficult to get, and it is very expensive. Let's leave hypoglycemia and give you an overview of Cushing's disease or Cushing syndrome. Just a basic review of the physiology, which entails a link up between the hypothalamus or the thalamus up at the top of this illustration, hooking up, causing the release of corticotrophin releasing substance that affects the anterior pituitary's production of ACTH or corticotrophin, which then stimulates the adrenal cortices to produce its hormones. And here we're discussing cortisol. And we'll find that the body functions via a negative feedback inhibition cycle, where normally if the cortisol levels are high, the trophic stimulus from above is decreased to allow for homeostasis. In the Cushing syndrome of the dog and the cat, where 85 to 90% of endogenous Cushing's is caused by pituitary reasons for either hyperplasia or micro or macroadenomas, we find that this negative feedback inhibition does not take place, and the body continues to produce the ACTH, thereby stimulating the adrenals, thus giving you a constant hypercortisolemic state. Here we show you a histopath. Let me just go back to the previous slide 1 second. The other 10 to 15% etiology for the endogenous Cushing is the adrenal gland tumor, which could be either an adrenal adenoma or an adrenal adenocarcinoma. Histopathologically, when we discuss Cushing's and its opposite disease, Addison's, we're looking at the adrenal cortex. And looking at the top of this slide, we have the zona glomerulosa, which is the site of the adrenal cortex for the production of the mineralocorticoid aldosterone. The middle zone is the zona fasciculata that produces the bulk of the glucocorticoid cortisol, while the inner zone of the adrenal cortex produces the 17 ketosteroids to produce the sex hormones from the adrenal gland. So when we're talking about Cushing's, we're particularly interested in the zona fasciculata and its elaboration of the cortisol because of the hyperplastic change that occurs to this area in the setting of pituitary-dependent Cushing's. As already mentioned, the three main etiologies of Cushing's are pituitary-dependent and the adrenal tumor, representing the endogenous etiologies. But then we have the iatrogenic cause of Cushing's, which is common in veterinary medicine because of patients that receive excessive amounts of steroid drugs for the use of treating either immune-mediated diseases or allergies. Okay, here we show you a little Yorkshire Terrier, if you could characterize this patient as such. This dog has advanced Cushing's syndrome. It has the typical hair loss pattern, which is truncal. We also see other skin changes characterized by the hyperpigmentation, as shown in this little dog. Clinically, the three most common signs in the Cushing dog are polydipsia, polyuria, and pendulous abdomen. There are many other signs, but those are the three most common. Here we see an illustration of one of the more rare clinical signs due to Cushing's, that being calcinosis cutis, and this dog shows mainly the inflammatory form, which were located in both the groin area and the axillae. Here we show you a poodle that would present to us with polydipsia, polyuria. The owners noted some less exercise. The dog was inactive. This dog might also be polyphagic. We see here that we do have a hair loss pattern in this patient. The belly is distended. On a dog, we might also detect hepatomegaly, but we won't pick that up in the feline Cushing most of the time because cats are not as susceptible to steroid hepatopathy as dogs are. We'll show you a sample serum chemistry workup in these Cushing patients, and you could see on part of the data here shown what we see commonly are elevations in the blood lipids, which might register in the form of elevated cholesterol or triglycerides. Very common is the elevation in the alkaline phosphatase and the other liver enzymes, with the ALP phosphatase being the most commonly elevated routine serum chemistry. Sometimes the blood glucose is elevated if the patient is going to be a diabetic at the same time. The urinalysis is important to do on the Cushing dog and the diabetic, I might go back to say, because of their increased susceptibility to lower urinary tract infections, and that's why it's imperative that you get your urine sample by cystocentesis so that if there are bacteria, you can use that same sample for culture and isolation. The use of imaging is helpful for honing in on the etiology of Cushing's. Plain radiographs of the belly might show the distended belly and the hepatic enlargement. We might also see by chance a calcified adrenal gland tumor if it happens to be there. We could also use early phase pyelograms and arteriography to highlight that kidney adrenal area. We're also commonly using today abdominal ultrasonography to denote any abnormal adrenal gland asymmetry that will help us identify any adrenal tumors. Pituitary CAT scans and MRIs are used to analyze the presence of pituitary gland tumors. The other diagnostics for Cushing patients involve certain stimulation or suppression tests. Here I show you the ACTH stimulation test, which is a commonly done test. If we look at the middle part of the graph, we see the normal dog responding to ACTH, where we have over a period of time, such as an hour, we see the cortisol levels increasing in the normal dog and then going down. In the Cushing dog, we see far in excess the elevations in the serum cortisol level, and this would be compatible with an endogenous Cushing dog, but this will not distinguish between the pituitary nor the adrenal tumor dog. We'd have to go to other tests. Here we illustrate the low-dose dexamethasone suppression test, which will be used to diagnose Cushing's. We find that the white bar illustrates the normal dog, where after the 6 to 8 hour mark we find adequate suppression, whereas the gray and the blue bars show that you will not get suppression in the Cushing dog, whether it's caused by pituitary or endogenous etiologies. To help distinguish between the pituitary dependent from the adrenal tumor, we call upon the high-dose dexamethasone suppression, where we will find that the dog with pituitary dependent will suppress from approximately by around 50% of the baseline value, as shown by the middle bar, whereas the adrenal tumor, as shown by the bar on the right, will maintain its high level and thus showing that it is non-responsive to the high dose of the dexamethasone administered to that patient. The treatment of Cushing dogs in this country, when we're talking about endogenous Cushing's, especially pituitary, entails the use of the drug lysergin, also known as mitotane or OPDDD, which is an adrenocytotoxic drug, and therefore it will behoove us to know the pharmacology of this drug and its shortcomings as far as the signs of toxicity. But this is the most commonly used way, or this is the most efficacious way of managing Cushing syndrome in dogs with pituitary dependent disease. Okay, let's go on to Addison's, and here we're talking about adrenocortical hypoplasia, or hypoadrenocorticism. The Addisonian patient that comes in is oftentimes going to be a sick patient, either a dog or a cat. This disease is more common in the canine. Certain breeds are more predisposed, such as the standard poodle and the Great Dane being common ones. And these patients will give you a period of not feeling well for either days or weeks duration. They'll have decrease in appetite, decreased exercise activity. They then go on to show signs of vomiting and go into a full crisis situation, as this dog was, as he presented in lateral recumbency, showing you signs that warranted emergency treatment. The pathophysiology entails the patient being deficient in both cortisol and aldosterone. And here I show you an illustration of what aldosterone, the mineralocorticoid of the body, normally does. And namely, in the normal animal, it allows for sodium retention at the distal duct of the renal tubule. So it allows for sodium and chloride retention, and it facilitates potassium and hydrogen excretion. Therefore, if we were to have a deficiency of aldosterone, we would have sodium and chloride wasting, and we would accumulate the hydrogen and potassium. The end result being a patient that has hyperkalemia with hyponatremia. And don't forget, these patients are cortisol depleted as well, and that has caused them to have this sense of sickness, this state of ill-being, lethargy, decreased appetite as a result of the cortisol. And the low cortisol also contributes to the low blood pressure that these animals have. Here we show you an illustration of the cardiotoxic effects of hyperkalemia. And at the top, we'll give you the normal PQRS T complex. As the potassium increases, we'll start seeing an increase in the potassium, which is the second positive spike in that middle complex. So with early hyperkalemia, the potassium, the T wave will either increase or decrease in its amplitude. We could go below the baseline with that T wave as well. As the potassium goes up higher, we'll find that the P wave, as in Peter, will get short and flattened. The patient will go into bradycardia, and you might even lose the P wave. And the loss of a P wave in the presence of a bradycardia gives you the EKG pattern known as atrial standstill. And as the potassium goes up even higher, we'll get the wide sine wave type of pattern, or this M complex as shown on the bottom, that is the crisis sign of myocardial toxicity, and the patient might die at that point. In the laboratory, we might find a hemogram showing a decrease in neutrophils and an increase in eos and lymphocytes in the classic Addisonian, but these hemogram signs are not to be counted on. The classic patient shows chemistry abnormalities, including hyperkalemia, hyponatremia, elevations in the BUN, and they might even have, in fact, acute renal failure. Some of these Addisonians can have low blood glucose, and because of the renal failure and the hydrogen ion retention, it doesn't surprise you to find the low bicarbonate associated with their metabolic acidosis. The diagnostic gold standard test is the ACTH stimulation test, and what you would expect on that test is the lowest possible value for cortisol in these patients. Oftentimes, the post-stimulation test is less than 1. So we've recognized the patient, and now we have to treat it, and the principles entail restoring volume with 0.9% saline, replacing the glucocorticoid with prednisone sodium succinate, providing mineralocorticoid with either Florinef, which is known as fludrocortisone, or there's an injectable drug known as DOCP, the latter of which is given sub-Q, and which might be of more benefit to the patient if it's vomiting. When the patient has EKG signs of hyperkalemic myocardial toxicity, we might have to give additional agents such as insulin glucose combination or bicarbonate or calcium gluconate injection to help offset these myocardiotoxic signs. Okay, we'll now leave the Addisonian, and we'll discuss the pheochromocytoma, which is a tumor of the adrenal medulla. And when we think of adrenal tumors, we think of tumors that are going to produce, if they're functional, catecholamines such as epinephrine or norepinephrine. I'll give you a sample patient of mine. This is Blackie. She had a several-month history of paroxysms or episodes of waxing waning periods characterized by her being anxious, hyperventilating, pacing, signs representing this hypercatecholamine secretion by this adrenal tumor. And it took me a while to diagnose this because it was such a rare situation back in the 1970s, actually. And eventually we did diagnose it, and we were able to send her to surgery. Here I show you her arteriogram of the pyelogram, showing you the mass lesion that is just medial to her left kidney. That's to your right as you look at the screen here. We see that round density, thus representing her adrenal gland tumor, which was diagnosed at surgery as a pheochromocytoma. When these patients go to surgery, we have to monitor them very, very, very closely for swings in blood pressure to make sure that the surgical manipulation does not cause any extremes in either hypotension or hypertension. Here we see a radiograph of a venogram from a dog that complained of ascites, or the owner complained of the dog having ascites, and we were suspicious for a pheochromocytoma. How we get the ascites is the fact that approximately 50% of the pheochromocytomas are malignant, and thus being malignant, they can invade nearby structures. Thus, in this case, invading the post cava, as we illustrate here, the post cava in a contrast study, showing you the broken up pattern that is caused by the tumor infiltrating this patient's post cava. This, of course, would be a non-treatable disease from the surgical standpoint. So if the patient cannot be treated surgically, we might be able to control its hypertension that it has with a drug known as phenoxybenzamine, which works by alpha-adrenergic blockade. If the dog has a tachyarrhythmia, we could treat it with propranolol, which is a beta blocker. Whenever you use these drugs together for a pheochromocytoma patient, it is essential that you alpha block them before you beta block. So think of it in terms of A and B. A comes before B, where phenoxybenzamine is always given before we give propranolol to avoid any abnormal blood pressure swing. Feline hyperthyroidism is our next category. This has become a very commonly diagnosed problem of the cat ever since the 1980s. Clinically, these patients can be silent, but as time goes on, their signs can be more overt. Pathologically, 98% of the thyroid masses that we see are benign in the form of adenomatous hyperplasia. We'll find that 70% of the hyperthyroid cats have bilateral disease, with only 30% having unilateral disease. On physical examination, the patients might show signs of weight loss. The owner's complaint would be weight loss in the setting of increased appetite. The owners might also complain of hyperdefecation, periodic vomiting, and overactivity, all signs that are very compatible with this syndrome. On clinical examination, we might have abnormal cardiac signs, and we might be able to pick up by palpation, either unilateral or bilateral thyroid gland enlargement. We refer to enlarged thyroid glands as goiters, as shown here in this cat. Some of these little patients can have such a high degree of hyperthyroid activity that they literally present exasperated. And here we see this little kitty that was panting, and she had a marked sinus tachycardia with her heart rate as high as 300. And it would benefit this patient to lower her heart rate a bit before treating it with something like I-131, or if you were to surgically remove the thyroids. The specific diagnostic tests for diagnosing hyperthyroidism in the cat are several, and not to confuse things for you, I'm going to say that the total T4, just a regular T4, is the most commonly used test to diagnose over 90% of your hyperthyroid patients. These other tests have been described in the veterinary literature, and we rarely have to resort to them to diagnose this disease in these patients. Thyrotoxicosis is a term to recognize the patient who has heart disease occurring from the hyperthyroidism. And here we see a pathological specimen of a cat who had cardiomyopathy, but the pathology that we can find with the thyrotoxic heart might mimic thyrotoxic heart disease. And clinically, this would mean a patient on a radiograph would have an enlarged heart, and on an EKG might show you elevated R waves, as well as having abnormal rhythms such as sinus tachycardia. Treatment of the hyperthyroid cat can be either medical or surgical. The medical treatments would first call for slowing any abnormal heart rates down with a drug such as a beta blocker like propranolol, or you could use a calcium channel blocker such as diltiazem. We would want to use an anti-thyroid drug which would impair the thyroid manufacturing of the products T3 and T4. And of these, today, methimazole or tapazole is the most commonly used drug. Radioiodine, where available, is a very nice way to treat a hyperthyroid cat because you won't have to have the patient do lifelong treatment, as they would in the case of methimazole, which has to be given on a daily basis, so long as the patient does not show any toxic effects from the tapazole. The surgery is an option. You would do a unilateral resection for unilateral hyperthyroidism and bilateral resections for the patient with bilateral disease. When you do the bilateral removal, it is essential that we take care to leave at least one or two parathyroid glands without any residual thyroid tissue. Now, we want to leave the parathyroid intact because with bilateral resection, you do not want to leave the patient hypoparathyroid. Through surgical manipulation, however, some of these patients might still be hypocalcemic post-op because of ischemic changes that we have caused to the remaining parathyroid gland from the surgical resection. But hopefully over days to weeks, that parathyroid gland will reactivate to produce parathormone and thus avoiding the threat of hypocalcemia. Kidney disease has to be considered when you treat a hyperthyroid cat, because if a patient has chronic kidney disease, as would be illustrated with polydipsy-polyuria and palpably small kidneys and urine that is within the isostenuric or 1008 to 1012 range, these patients are susceptible to going into renal decompensation after we make them euthyroid. So if I have a patient with signs of hyperthyroidism and chronic kidney disease, I will not opt for total thyroid ablation through either surgical or I-131, but instead recommend oral treatment with tapazole so long as the patient is tolerant, thereby allowing the thyroid level in the blood to remain slightly above normal to benefit the kidneys, yet low enough to prevent the signs of hyperthyroidism in the patient. Okay, we'll now go on to acromegaly. Acromegaly is a condition whereby the body has too much growth hormone, and this does occur in the dog and it does occur in the cat. In the dog, acromegaly is a result of a hyperprogesterone state, which is brought about by either the patient producing progesterone excess during its own diestrus, or that which is gotten by injection when progestogens are used in other clinical conditions, such as contraception or behavioral control. In the dog, acromegaly is not a result of a pituitary tumor. In the cat, however, we'll find that the feline always has an underlying pituitary tumor producing excess growth hormone in the feline. Let me go back one slide to give you the signs of acromegaly in the canine. Those being, we might get a thickening of its digits, we might get a thickening of the hair coat, we might have the patient showing superfluous skin folds. Of what might be a dramatic presentation is labored breathing as a result of pharyngeal tissue becoming hyperplastic, thereby compromising the airway, and these patients come in with stridorous respiration. Some of these dogs also have mammary cancer because excess growth hormone can predispose them to mammary carcinoma. In the cat, the most common presenting sign for acromegaly is the fact that they will be resistant diabetics. We'll have cats on insulin dosages as high as 50 to 100 units per day because of the insulin resistance brought about from the acromegaly. We'll find that dogs can also become diabetic from acromegaly, but not every dog with acromegaly becomes diabetic. Whereas in the feline, by the time we diagnose them, every one of them has had diabetes at the time. Again, with the owner's primary complaint being insulin-resistant diabetic state. In the cats, because the etiology is due to the pituitary tumor, that mass might eventually grow large enough to cause central nervous system signs that we usually present as head pressing, dementia, signaling that the tumor has expanded significantly. This, of course, would be visible on an MRI or a CAT scan. Diabetes insipidus. And here we're talking about a deficiency state of antidiuretic hormone, otherwise known as vasopressin. We abbreviate antidiuretic hormone as ADH. These patients urinate and drink a lot, and they make no secret of doing that at all, believe me. The etiology of the diabetes insipidus can be twofold. They can come from the pituitary gland, otherwise known as pituitary diabetes insipidus, or they can be nephrogenic diabetes insipidus because of the patient's resistance to its ADH at the collecting duct part of the renal tubular system. We can see here in this illustration that as far as pituitary diabetes insipidus is concerned, that this might result from a granuloma or a tumor or even trauma, thereby interfering with normal function involving the hypothalamic neurohypophyseal secretory stalk or the posterior pituitary gland. We find that the posterior pituitary gland stores the hormone where the hypothalamus actually produces the hormone ADH. And we see here that the hormone will be secreted from the posterior pituitary gland and go down to the distal renal tubule, where it allows for water reabsorption when ADH is present. So you can appreciate in the absence of ADH that the patient will not be able to reabsorb the water passing through the tubule, thereby experiencing its water diuresis. And if the patient doesn't drink to compensate for this water loss, it will soon become hypertonic and eventually very dehydrated. The diagnostic tests we use are, number one, water deprivation, which tests the animal's ability to produce and secrete ADH. Thereby we could differentiate the diabetes insipidus patient from psychogenic polydipsia, whereby in the latter patient we will see them being able to concentrate their urine in response to water deprivation. Going back to the diabetes insipidus patient, they will not be able to concentrate their urine with water deprivation. We'll then give the diabetes insipidus patient an injection of ADH, now to see whether or not that patient can respond to ADH. If it responds to the ADH, as shown by an increase in the concentration of the urine-specific gravity or the urine osmolality or serum osmolality, then we can say that the patient has pituitary-dependent diabetes insipidus. If the patient does not respond to the ADH and persists with the hypostenuria and the polydipsia, we will now call it nephrogenic diabetes insipidus. Pituitary dwarfism, I just briefly want to mention here. This is it's a congenital problem involving the German Shepherd dog. It's a recessive autosomal inheritance disorder that's characterized by an abnormal development of the pituitary gland. And as a result of that abnormal development, the gland will produce inadequate amounts of the hormone somatotropin, and subsequently the patient will be small. Now, this might be the ideal apartment dog for South Florida. Here we see an acromega. Here we see a pituitary dwarf German Shepherd. We also see that it has alopecia and it has a fuzzy hair coat because of the lanugo hairs that are retained, but the adult hairs do not come in. Many of these dogs are also hypothyroid, and therefore it behooves us to measure the thyroid level in the bloodstream as well. The adrenal glands function normally in the dog with the pituitary dwarfism. I just want to briefly mention the hypercalcemic states. In veterinary medicine, in both the dogs and the cat, there can be several causes of increased blood levels of calcium. These are the hypercalcemia of malignancy conditions, as represented by lymphosarcoma, anal sac adenocarcinoma. We can also see primary hyperparathyroidism, which is due to either a parathyroid tumor or hyperplasia of the parathyroid glands. Osteolytic metastases from tumors such as multiple myeloma can dissolve enough bone to raise the serum calcium levels. Hypervitaminosis D, as brought about by high levels of supplementation to the pet's diet, or the patient getting into certain rodenticides that contain the cholecalciferol compound that's responsible for the hypervitaminosis D, which in turn goes on to cause nephrocalcinosis and kidney failure. Day-blooming jasmine is found in South Florida. Too much ingestion of this plant can cause high levels of the calcium. We can also get a little bit of hypercalcemia from secondary renal hyperparathyroidism. We can get a small degree of hypercalcemia from Addison's disease, but this is never of any clinical significance, and hypercalcemia of Addison's disease will go down when you treat the Addisonian as previously described. Granulomatous disease might produce vitamin D-like substances that can cause syndrome similar to hypervitaminosis D, thus giving hypercalcemia. Examples of the latter might be some of the systemic narcotic diseases such as histoplasmosis or blastomycosis. The treatment objectives for managing hypercalcemia include hydrating the patient, using 0.9 saline as the fluid of choice. We might promote the kidney's excretion of calcium by giving furosemide, but only implement this after the patient is rehydrated. We can inhibit bone reabsorption through the use of certain compounds such as the bisphosphonates, otherwise known as biphosphonates, that are commonly used in humans to treat bone metastases. And last but not least, treat the underlying disorder. If it's a patient with lymphoma and has the malignant lymphoblast in the bone marrow, we would want to treat the lymphoma to hopefully allow that patient to compensate. Hypocalcemia is when the serum levels are below normal. The usual established, the lower range of normal is 9 milligram per DL. We'll find the most common causes of hypocalcemia, and we're not going to see signs until the calcium levels drop below 7 milligram per DL, and the signs are mainly manifest with neuromuscular irritability. The primary causes include primary hypoparathyroidism, postpartum lactation, hyperphosphatemia, as might be brought about with the fleet enemas that contain high levels of phosphorus that can be eventually absorbed through the bowel, hypovitaminosis B, which is rare, and hypoalbuminemia. Why? Because 50% of the total measured calcium in the blood is bound to albumin, but it's the ionized calcium that is most important biologically at the neuromuscular junction. We treat hypocalcemia with drugs such as calcium gluconate, which is given IV at the prescribed dose, which comes out to be approximately, using 10% solution, 1 ml per kilo IV, given slowly to effect. And then we would have to maintain them on more slowly available calcium treatments, which the dosages can be found in the standard veterinary texts. Vitamin D is also used to treat the chronic hypoparathyroid patient, whereby we might find the calcium supplementation might not be enough, and we could take advantage of the fact that we can prescribe dihydrotachysterol or the 125-dehydroxyvitamin D to help them maintain normal levels. Hyperestrogenism is an endocrinopathy characterized by increased estrogens in the blood, and the most common causes of this in the dog and the cat are ovarian granulosa cell tumors or Sertoli cell tumors in the male that produce estrogen-like compounds, or we might have a normal female with cystic ovaries producing high levels. Here we see the posterior aspects of a female dog who has cystic ovaries. She has alopecia, and she might be dripping a serosanguineous fluid from the vulva because of her hypersecretory state. You can see by her vulvar prominence that she's under influence of excessive hormones. All of this is reversible if we were to remove the cause of the hyperestrogenism. We have to worry about bone marrow toxicity in the hyperestrogenism state, whether it's brought about by estrogen injections or that produced by Sertoli cell tumors or ovarian tumors. And we could find that we're going to see this particularly a problem when we look at the hemogram, where these patients would have a leukopenia, thrombocytopenia, and severe anemia. The severity is assessed by doing a bone marrow examination to see whether we have a hypoplastic or an aplastic situation. Ferrets are also extremely susceptible to estrogen myelotoxicosis as well. Lastly, we'll mention hypothyroidism, and this is going to be brought about most of the time by an idiopathic atrophy of the thyroid gland, or it might be brought about by inflammation of the thyroid gland in the form of thyroiditis, eventually leading the gland to be atrophic. You see here that hypothyroidism is broken down into three types: acquired primary or secondary or tertiary forms. But for all practical purposes, we deal with the primary acquired form of hypothyroidism, which again is an idiopathic atrophy or that brought about by chronic thyroiditis and eventual no more available thyroid cells functioning. The clinical signs of a hypothyroid dog would be those of lethargy, weight gain. We might find decrease in appetite, and then we might find a whole bunch of skin changes such as alopecia. Here we see the classic rat tail as shown in this dachshund. It's alopecic and hyperpigmented. We also see the posterior quarters of this dog are allopectic as well. We might find that these hypothyroid dogs have degrees of seborrhea. They might have a folliculitis. There could just be so many signs. I'm just mentioning a few. Here we show you a bulldog you might think is normal, but if we were to look at it when it's not hypothyroid, you would say, yeah, this dog looks pretty pathetic, doesn't it? And that's why we use the term of pathetic faces to describe some of these symptomatic hypothyroid dogs. They just look very, very depressed. As far as diagnosing hypothyroidism, we can use the free T4, and that would be determined by equilibrium dialysis as being the most sensitive test. You could also use the traditional T4, and you could also use the TSH level. But the problem we have with the TSH is that approximately a quarter of the dogs with hypothyroidism might have normal TSH instead of the predicted increased amounts as we would see brought about by the impairment in negative feedback inhibition. And lastly, as we come to a close here, once we make our diagnosis of hypothyroidism, we're going to treat it with the hormone thyroxine. And Siloxane is the thyroxine preparation that is most commonly used in veterinary medicine today. And you would follow the recommended dosages and checking that patient periodically to see how it is doing. So in closing, we have really run a long distance here in our marathon through endocrinology and the dog and the cat. I hope that I have sensitized a lot of your cerebri to these conditions that I'm sure a lot of you have been encountering over the years.